Greetings, everyone. Welcome to this lecture on passing gas, or actually End-Tidal CO2, but me being me, I like the lecture title, so there we're going to go with that. So, this lecture is on End-Tidal CO2, and it's going to cover quite a bit of ground in the next hour, hour and a half. So, I hope you enjoy it. So, we're going to talk about quite a lot here. We're going to talk about the difference between oxygenation and ventilation as kind of an understanding of how End-Tidal CO2 works. We're going to talk about End-Tidal CO2 itself, going to describe it. We're going to talk a lot about the pathology, honestly, and then that's going to help us understand what a normal capnogram or capnograph looks like. The reason why we're doing this is very much like EKGs. If you just learn EKGs without any context, you really don't know EKGs. And if you just learn End-Tidal CO2 without context, then you really don't know anything about End-Tidal CO2 and therefore aren't getting any of the benefit of it. We're also going to talk about, as part of that pathology, how it relates to PaO2, PCO2, pH. Then we're going to close up with understanding normal, or what I call essential capnograms and capnographs, such as tube dislodgement, hyperventilation, the shark fin, a few others thrown in there as well. And we're also going to talk a few pitfalls. Now, when you're done with this is going to be quite a lot of information over the next hour, hour and a half. And chances are, educational research shows us that only about half of it will stick. Well, please go back and review this again. But also, here's another great resource, and it's capnoacademy.com. It's brought to you by Medtronic, but it has Zoll stuff on there as well. Not a lot, but a little bit. And I hope it sticks around for a while. As you may know, Medtronic was purchased by Stryker, but I think they're still going to continue this. And it's a great resource. It has hundreds of End-Tidal CO2 capnographs on it and training resources. So let's talk about the basics of capnography. What is, when we look at the word End-Tidal CO2, let's look at the CO2 part. What is CO2? Well, it's carbon dioxide, of course, but where does it come from? Does it naturally appear in the air and we just happen to measure it? No, it comes from the respiratory tract. Well, it doesn't magically appear in the respiratory tract. It gets in the respiratory tract from somewhere. And what is that somewhere? Well, it's from cellular metabolism. And that's why this quote I absolutely love, that CO2 is the smoke from the flames of metabolism. It is an indirect but vital surrogate for how our metabolism is functioning. So when you understand that, you understand that End-Tidal CO2 is more than just confirming tube placement. It's more than just looking at and saying, okay, yeah, my albuterol atrovent or duoneb or zopanexneb worked. It is so much more, and when you understand that, then you're beginning to get into what End-Tidal CO2 can do for us. I like to think of End-Tidal CO2 that someday paramedic programs will put as much emphasis on End-Tidal CO2 as far as learning, interpreting. You'll have End-Tidal CO2 chat tests and such like that we do for EKGs. So, not to scare you, but that's what I would hope, because it can be that useful of a tool. So when we understand it, was there, some things I want to talk about in just the next few slides, or was the relationship to End-Tidal CO2 to say SPO2 and PaO2? Was the relationship between End-Tidal CO2 and PaCO2 and pH? And that will be useful in your basic foundation understanding End-Tidal CO2. So a crucial concept is to understand that oxygenation and ventilation are two separate processes. We often teach them together. We talk about them as if they are interrelated, but they're really two separate processes that just happen to occur and exist in the same place and time. They occur, oxygenation and ventilation occurring, we talk about cellular oxygenation and ventilation, or respiratory oxygenation and ventilation, mechanical oxygenation and ventilation. They occur in the same place and time, but the factors that affect them are often different. Oxygenation we measure by SPO2 indirectly. That's partial. That's your pulse ox, right? which is an indirect measurement and often incomplete measurement of PaO2, your partial pressure of arterial oxygen. Your ventilation we measure through End-Tidal CO2, which is how much CO2 we're getting out through a tidal breath, and more specifically, we measure it at the very end of the tidal breath because it can vary depending on where you are in the phase of the tidal breath. Okay, so that's why we have end-tidal CO2 instead of just tidal CO2. Oxygenation is a reflection of what's going in, and CO2 is a byproduct metabolism, and we're measuring what's coming out. Now, the human body, if it's at rest, key point at rest, breathing normal ventilatory rates with normal blood pressure and everything else, and you'll find out why blood pressure is important, consumes about 250 milliliters of actual oxygen a minute. However, it only produces, assuming that you have normal body temperature, normal metabolism, at rest, about 10 milliliters a minute of CO2 production. Now, I'm not going to get into what we call nitrogen washout and pre-oxygenation and apneic oxygenation in this, but those two concepts are crucial for those discussions as well when you talk about your pre-oxygenation for RSI and airway management. So we only produce about 10 milliliters of CO2 a minute. That's not a lot, but we measure it. We measure it as we exhale it, and that's where End-Tidal CO2 comes in. So if we produce more, or I should say we have an accumulation of more, like in the case of hypoventilation, that will be reflected in our End-Tidal CO2. And so how does this get into the respiratory tract? Well, picture this is an alveoli. Let me get my little handy-dandy laser pointer here. This is an alveoli, grape-like three-dimensional structure. We have a two-dimensional image here, so you'll have to use your imaginatory powers. And it is surrounded, as you see with these little blue lines, by a capillary blood supply. If you recall, capillaries are just a cell layer thick as far as their walls. And then you have the alveoli with essentially a cell layer thick alveolar wall. So you have two cell layers that are right next to each other. And the key part of that is that they are semi-permeable, which means they're not completely solid. There's gaps in between these cell walls. And the gaps are small enough that fluid doesn't normally leak across, but certain gas can. And this is passive. This is a passive process, and when you learned all that boring stuff about osmosis and diffusion, this is where diffusion and osmosis come in, and pressure gradients. Now, so how does that come into play? Well, things that affect the distance in between the cell layers, the things that affect the distance between the cells that make up those cell layers, can affect how much gas goes across and if fluid goes across, as well as the blood pressure in the capillary bed or the atmospheric pressure inside the alveoli. All these play a role. And we're not going to hammer that too much, but it does illustrate how this knowledge intersects with how CPAP and mechanical ventilation work. Our understanding of how CHF and cor pulmonale and pulmonary hypertension and pulmonary edema and all that stuff all kind of overlaps here. Now, why this gas exchange occurs based on passive diffusion. If you remember, passive diffusion is movement of a particle, whatever that particle is, from higher concentration to a lower concentration to equal out. So in this case, oxygen, if we have lots of concentration of oxygen molecules here and a low concentration here, the molecules will attempt to equalize through passive diffusion and travel across to the bloodstream where hemoglobin picks it up and takes it wherever it's going to go. I'm sorry, I'm going the wrong direction here. You get the idea. So by understand that principle, you understand how increasing the oxygen content here, the percentage, actually speeds up and increases the oxygen content that jumps across. Because when you have a much higher concentration of whatever your product was here, it naturally wants to equal across at much higher, or diffuse across at much higher levels to the pulmonary capillary bed, so you get increased oxygenation. The opposite is also true. You have a higher concentration of PaCO2, of CO2 coming from the body over here, and it wants to equalize across passive diffusion and dump CO2 in the alveoli to be eventually washed out with the next breath. Now here's a little interesting thing I want you just to consider. There comes a point that if you aren't ventilating, where that point of equilibrium means no gas exchange occurs. No gas exchange occurs, where either, if we'll say you're not ventilating at all, the patient's in cardiac arrest or respiratory arrest, no more oxygen is getting here. Eventually it will equalize across and there will be no more oxygenation. You also eventually reach to a point where your PaCO2 and the CO2 in the alveoli become equal and there's very little gas exchange. But also keep in mind that if there's gas exchange, that your CO2 no gas exchange, this will build up, this will become higher. It will then diffuse across, point of equilibrium will go higher, and you'll get large amounts of CO2 build up in the alveoli until eventually the patient dies or you start washing it out. So I hope that makes sense. So this relationship between ventilation, let me go back one. Another key factor here is the perfusion in the capillary bed. Okay, so if you have great perfusion, that's going to facilitate diffusion and the attempt to achieve equilibrium. And if you have poor perfusion, it's going to affect that as well. So this is what we call ventilation or perfusion, and the respiratory abbreviation for ventilation is V, and perfusion is Q. Don't ask me why it's Q, but it just is. So when they talk about VQ or VQ mismatch, we're talking about variation between ventilation and perfusion, a disparity there. So if your VQ equation is equalized, you have good perfusion and you have good ventilation, movement of gas. If your VQ is compromised, here we see low ventilation, and we see that you don't have gas exchange, even though you have good perfusion. The opposite could be true. You could have low perfusion but okay ventilation, in which case that you have you still have compromised. You can either have overventilation that compresses the capillary bed, and you have, as a result, you have, or maybe a PE that compromises it, where you have a difference between ventilation and perfusion. Your perfusion is compromised, and therefore you still don't have oxygenation. Hope that makes sense. So as we talked about already, CO2 is the byproduct of cellular metabolism. That's how it gets into the bloodstream and then gets into the alveoli. But end-tidal CO2 is then when it gets in the alveoli and it's washed out through ventilation, mechanical ventilation, we measure it. We measure it at the very end of that cycle when it should be, in theory, the highest point before we take a breath in. So when you breathe out, if you could hear that, at the end of that breath, that's when we measure end-tidal CO2 before we take a breath back in. Because when we take a breath back in theory, we should not be breathing in any end-tidal or any CO2, and our CO2 levels should immediately drop to 0 in our respiratory tract. Now, we use this to gauge the effectiveness of respiratory interventions, but also as an indirect measurement of metabolism. So with that in mind, what can we assess with end-tidal CO2, both directly and indirectly? Well, I've already given you all the answers to this. We measure metabolism, we measure the perfusion in the capillary bed, and we measure ventilation. And all three of these are important. All three of these are important. So if you thought end-tidal CO2 is just focusing on tube placement, you've missed a huge part of its usefulness. So in order to measure end-tidal CO2 as opposed to PaCO2 and other variations, PvCO2 is such a thing, but in order to measure end-tidal CO2, well, the old expression is air goes round and round and blood goes in, or air goes in and out and blood goes round and round, and each variation is a bad thing. Well, that's true here. Air has to go round and round and in and out. That's the ventilation. And blood has to go round and round. That's perfusion. And there has to be some cellular activity left. That's metabolism. Those three things have to be working in synchrony, in harmony, in homeostasis, in equilibrium to get good end-tidal CO2 readings. So when you get abnormal end-tidal CO2 readings, then based on the shape, based on the context, based on lab factors, we try to figure out which one of these three parameters has gone awry. Okay? Let's look at the numbers. When we look at end-tidal CO2, it is measured in millimeters of mercury. Now, I will say that some of the older references reference torr, which is a very similar but slightly different measurement, but most contemporary documents and most contemporary monitors measure this in millimeters of mercury. And the numbers are 35 to 45 millimeters of mercury. And I like to think of this very similar to what you see with your PaCO2, which is measured also in 35 to 45. Now, if it's in range, this is sometimes referred to as normocapnia. And of course, if it's below that, it's hypocapnia. And if it's above that, that's hypercapnia. Now, before this lecture, if you were just looking at the numbers by themselves, you might think that this was just simply a reference to how fast or how slow the patient was ventilating or you were ventilating for them. But there's a lot of things that can affect this number. So this number in and of itself is useless without context. So you can actually have quite a bit of variation. So it is true that you can affect this number through respiratory rate. So in theory, if you bumped up your respiratory rate, you'd breathe off more end-tidal CO2 and your end-tidal CO2 would drop. And incidentally, you could also affect your PaCO2. And we see this with hyperventilation, where a patient has a respiratory alkalosis through breathing off too much PaCO2, and we see that reflected in breathing off and dropping our end-tidal CO2. This also is a factor of over-aggressive, positive pressure ventilation. And sometimes it's a compensatory mechanism for metabolic acidosis. So what we see here is we see an attempt to breathe off extra CO2 to compensate for metabolic acidosis, and it usually is ineffective. It's a compensatory but ineffective compensatory mechanism. We also see the opposite, that for respiratory rate drops, our end-tidal CO2 increases, and by relationship, our PaCO2 increases. It builds up. This is hypoventilation or hypocapnia. It also results in hypercapnia, not hypercapnia. We see this with apnea. We see this with CNS depression, like with benzodiazepines, opioids, GHB, etc. And we also see this through other mechanisms. I also will point out sometimes our end-tidal CO2 jumps up. Never mind, we'll talk about that later. So when we look at that and you look at this, you think, oh yeah, well this is just a factor of hyper or hypoventilation, but there's other metabolic causes. For example, if your body temperature increases. If If your body temperature increases either through exertion or through toxicological issues such as methamphetamine, through agitated delirium, through inability to offload heat, this increases CO2 production because it increases your metabolic oxygen consumption and other factors. And therefore, even with normal ventilation, your end-tidal CO2 may be much higher than this. The exact opposite is also true. In shock states, in hypothermia, your CO2 production may be markedly less, even though your respiratory rate is normal. In PEs, because of perfusion, and if PE blocks off your pulmonary capillary circulation, a pulmonary and by big clot prevents blood flow to huge portions of your pulmonary capillary bed, you can be breathing normal, but your end-tidal CO2 can be in the toilet. So it's really important to understand that while respiratory rate can have an effect on end-tidal CO2, it's only one part of a very multidimensional issue, of a multidimensional metabolic process. So let's look at some things that increase end-tidal CO2. Fever increases CO2 output, so you should see increase in CO2 output if you have a significant fever, infection, whatever. Malignant hyperpyrexia or malignant hyperthermia will definitely do this. You see this with certain medications, including, if you aren't aware, succinylcholine in certain populations, particularly those of Dutch descent. Sodium bicarbonate use, because it binds, it actually will make a patient more alkaline. You'll have some increased release in CO2 as you try to breathe. Right? Breathe it off. If you have a compression of a major extremity, either a tourniquet or a traumatic compression, then you release that compressive force and all that nasty blood suddenly hits the central circulation to include the pulmonary capillary bed, then you will see a huge spike in your end-tidal CO2. Pulmonary perfusion. Things that improve pulmonary perfusion, such as increased blood pressure, increased cardiac output, can also affect the amount of end-tidal CO2 you get, depending on what's going on. Things that affect alveolar ventilation, such as hypoventilation. And what this is, it basically the alveolar ventilation, the mechanical ventilation, isn't washing it out, so it builds up in the alveolar space. Then we intubate them and we put end-tidal CO2 on it, and it's through the freaking roof. The highest I've personally seen has been 117. A few months ago, we had another medic on an opioid overdose, have 121, something like that. Now, here's the thing, is that if it was just a thing, it was just build up with end-tidal CO2 in the alveolar space, a few breaths would wash that out. But they also have a profound acidosis, an actual acidosis from being, hypoventilation for several hours. And it takes hours to resolve that. It's not just a respiratory acidosis issue. It's then at that point a metabolic acidosis as well. You have bronchial intubation that can, suddenly you've had a unsecure airway, now you secure it, now you're moving air, get better. Yep. Partial airway obstruction can cause buildup of end-tidal CO2, buildup of CO2 in the alveolar space, and then when we intervene, we resolve that. Rebreathing of airway gas. So this, sometimes you hear people talk about dead space ventilation. And what this basically means is this is a case where either our tidal volumes are so low that we don't ventilate out all the CO2, so they end up actually breathing some of it back in. It gets trapped in what we call the dead spaces of the upper respiratory tract. It also, sometimes we see this when you have really long ventilatory circuits that increase dead space and give a chance for CO2 to be trapped. These are concerns. And sometimes we have issues with inadequate O2 flows. Again, not washing out all the CO2 out of the alveolar space. You have leaks in your breathing system. You have a bad ventilator, you have an incompetent one-way valve on your BVM, and we've talked about that before. Things that decrease CO2 output, the big one is hypothermia. Now, this is a misnomer. I'm going to point this out. It is true that epinephrine has an effect and will drop your End-Tidal CO2. It's not so much decreased CO2 output. It's that it constricts. There is some documentation that large amounts of epinephrine, consistent with the amounts we give in cardiac arrest, will actually cause possibly what we call stone heart syndrome, which will transiently, for a few beats, affect how well the heart or compressions is pushing cardiac output, and will also cause vasoconstriction of the pulmonary capillary bed, which of course would decrease CO2 transferring across into the alveolar space. So it's not actually accurate that decreases CO2 output. It just decreases the perfusion of CO2-rich blood through the pulmonary capillary bed for a very short period of time. Now, the question is, how important is that? And that's a question that we've really struggled to answer. That leads us into other causes of pulmonary perfusion, such as reduced cardiac output. And this is why a sudden drop in End-Tidal CO2 can be a predictor of cardiac arrest, because as the heart is becoming weaker. Hypotension, just systemic hypotension, systemic hypovolemia, a big PE, or actual cardiac arrest. Sudden decreases in End-Tidal CO2, the very first thing we need to look at is alveolar ventilation. In other words, have we lost our tube? Has our tube become dislodged? Has it become disconnected? Anything like that. Total airway obstruction with a big mucus plug, or the tube gets kinked. I've seen this a number of times where whoever you have on airway duty, on ventilation duty, isn't paying attention to the tube, and it gets folded over. It gets folded over your tube holder, and then it gets obstructed. And of course, we talked about circuit disconnection, or when they say sampling tube, they're talking about a leak in the tube of the End-Tidal CO2 Sidestream Capnography. We'll talk about that. Now, people ask me, what's the relationship of End-Tidal CO2 and SPO2? Well, they exist, just like oxygenation and ventilation. They exist in the same place and time, but they're separate processes. Now, as a general rule, End-Tidal CO2, if everything's going well, will give us clues that something is happening within seconds. Whereas we talked about SPO2 is often delayed by 60 to 120 or even 240 seconds, what we call saturation lag. Because SPO2 measures in an extremity what's going on in central circulation, and End-Tidal CO2 is an indirect measurement directly of central circulation because of pulmonary perfusion. So just to illustrate that, I want you to just take a moment, and you can pause this video to contemplate this if you need to. But I'd like you to just take a moment and imagine you have End-Tidal CO2 hooked up to yourself or to your patient via endotracheal tube. Everything else is going fine. You have an EKG in place, you have a pulse ox in place, and suddenly you just decide to stop breathing for them. What would happen? Well, almost immediately you would stop having an End-Tidal CO2 waveform. That would tell you something immediately, as that the patient was not moving air in and out, and CO2 as a result. Probably within about 30 seconds, you would see either an increase or decrease in the heart rate. You'd probably see very quickly, if everything else was normal and they were well oxygenated beforehand, you'd see tachycardia as the heart started to compensate, and then you'd see bradycardia. If the patient was already on that clinical cliff, like we see in many of our patients that we intubate, you'd see bradycardia very quickly. So either way, you'd see EKG changes in about 30 seconds or so. But it would be a minute, 2 minutes, maybe more before you saw a change in pulse ox. Now you might think, based on this, all we need is End-Tidal CO2. That's most important, and that is absolutely incorrect. We want to monitor all three because they monitor different parts of the physiological processes. Monitoring SPO2 and End-Tidal CO2 and EKG provides us more insight than any one by itself. So the sum is greater than the parts. It is a three-dimensional assessment, and they all go hand in hand. Matter of fact, this was so significant that in one study of anesthesia-related mishaps, that they saw a 90% reduction, in mishaps and a better prediction of mishaps before they occurred when you monitored all three compared to any two or any one. Now, in contemporary terms, we would never consider not monitoring all three, but in the 80s and 70s, that would be an issue. So this is a case of an older study actually informing our practice today. So what is the relationship? I've really talked about how oxygenation and ventilation are two separate issues, but what is the relationship between end-tidal CO2, what we measure at the end of a tidal volume breath, and PaCO2, the measure of CO2 in the bloodstream? And they are closely related as long as the pulmonary bed is well perfused. In general, your end-tidal CO2 is about 5 to 8 millimeters of mercury lower than your PaCO2. So your end-tidal CO2 at 30 could be more between 35 and 38 on your PaCO2. And that's fine. That's fine. That's perfectly good. That's a close relationship. It is predictable. And that's what we like. And that's because our end-tidal CO2 is a reflection that we measure, is a reflection both of perfusion and metabolic function. So because CO2 is related to, or PaCO2 has an effect on pH. Remember blood gases, all your blood gas lectures on how if you change CO2, you can change your pH. The question is, if we change end-tidal CO2 through underventilation or overventilation, does that also change pH? And the answer is yes. In general, a change in end-tidal CO2, an increase of 10 millimeters of mercury, causes a decrease of 0.08 in pH. Remember, our pH numbers are 7.35 to 7.45. So a 0.8 change is actually quite significant. A decrease in CO2, PaCO2, end-tidal CO2, results in an increase of pH of 0.08, predictably if everything else is equal. So in this top example, we slow down our ventilation, our end-tidal CO2 increases, we build up CO2, our pH drops, we become more acidotic. In this case, we breathe faster, we drop our end-tidal CO2, our pH increases, we become more alkalotic. Now, we'll tell you, key point, if you're listening, if you haven't toned out, that you may see a question like this on your midterm and final exam. You may see a question like this on your midterm and final exam. Forewarned is forearmed. So what is the impact on end-tidal CO2 and epinephrine? And we already alluded to this, is that we know that that epinephrine administered, and this is from a study in 1990 in the Annals of Emergency Medicine, Dr. Martin, G.B. Martin and company did this, that there was a significant increase in coronary perfusion pressure after epinephrine. But this resulted in a decrease in end-tidal CO2. And this occurred both with epinephrine and norepinephrine. So the question is why? And this was actually done during chest compressions and so on and so forth, and lasted occurred within 1 minute of administration of epinephrine. So we're pretty sure there's a strong association there. So it affected coronary perfusion pressure significantly, but for some reason, end-tidal CO2 dropped, and the question is why? What we think is that the pulmonary capillary bed is especially prone to the vasoactive, has a lot of alpha receptors of both epinephrine and norepinephrine. Now, whether this has an adverse effect on resuscitation, that is an excellent question. That's something that is still, even though it's been almost 30 years later, they're still trying to figure out the relationship there. So, but what you can see is that you will see a decrease within 1 minute of epinephrine administration in your End-Tidal CO2, but should resolve very quickly. What this also tells us is, or what another aspect is, that there are some things coming in the future that will talk about the use of epinephrine and End-Tidal CO2 as a hemodynamic parameter, as a biological parameter, or whatever term you want to use. So you will see something in the future where they are talking about using End-Tidal CO2 as a gauge for whether you should administer epinephrine in cardiac arrest. So for example, if your End-Tidal CO2 is above 20 or maybe 25 millimeters of mercury, you may see in the future, and there are some agencies doing this now, but not a lot, you may have a protocol that says don't give epinephrine at all. Because at that point, you got good perfusion, so epinephrine's not going to improve it, but it may have some other adverse outcomes. By contrast, if your End-Tidal CO2 is less than, say, 20 or 25, you may give either a normal dose or a half dose of epinephrine, trying to get your perfusion up without the adverse effects of epinephrine itself. So this is something that's coming in the future, I hope. So we've talked a lot about the physiology of capnography, the metabolic parts of capnography. Let's talk about capnography as a technology, because you have to understand how the technology works in order to understand what you're reading as well. So there's three basic types of capnography. There's capnometry, which is just a numerical display. There's capnography, which is the measurement of the graphical display, the waveform, and the capnogram is often described as the waveform itself. So put another way, the capnometer is the number, the capnograph is the number plus the waveform. And if you haven't gotten it, you haven't figured it out by now, now's the point when I tell you that a number without the waveform is almost useless. The waveform is where it's at. There's also a third type called colorimetric End-Tidal CO2. And this has a place, but honestly, I do not consider this capnography. What this is this has a piece of litmus paper in it. Litmus paper, if you remember chemistry, changes color with the pH of the air or whatever liquid's on it. And it measures, or it changes color because the pH of the gas that's exhaled changes, and that's an indirect measurement of End-Tidal CO2. It's strictly for use in tube conformation. Strictly for use in tube conformation. There's no waveform. There's no precise number. It's only good for 1 or 2 minutes. And it's only good if you don't have a lot of moisture in your tube. After that, it's useless. So it's just for a quick spot check, and it's got to get rid of it. Here's another thing. If it's opened and just sitting in your bag, the package is open, it's been exposed to air for too long, and it's no good either. So it's easy to spoof. This is good for a quick check. It's lightweight, requires no electronics, no batteries, but it has strong limitations. So if you're using this as End-Tidal CO2, you're kind of behind the 8 ball on that. Now there's something called mainstream End-Tidal CO2. Mainstream End-Tidal CO2. And what this basically is, if you see this device here, you have your disposable piece of plastic which you place on your End-Tidal or your ET tube or your BVM. And then the sensor is right here. It's self-contained in this with a cable running to the monitor. And you see example here, and I've never actually seen this in person, but these images are out there on a non-rebreather for spontaneous breathing patients also. You will also see this in various other forms. And often these are hooked up in the respiratory circuit. So here's a ventilatory circuit going to ET tube, this to the vent, and it just plugs in right there. So these are good in that they are almost instantaneous with each tidal volume breath, because they are measuring directly the airflow, and they aren't subject to getting contaminated by a lot of vomit in the tube because there's no direct connection. What it does is it shines that infrared light through this chamber, and based on the reflection of light off different gas, it can measure End-Tidal CO2. The old Zoll M series, and I think the E series used to use these. Now the downside, why they're not used as much anymore in the EMS setting, is they take about 30 seconds to quote unquote warm up and calibrate. And they also you look at this is a bit of weight on the end of an endotracheal tube, and you really don't want that in the pre-hospital setting. The more weight you have on an endotracheal tube, this can pull it out, cause dislodgement, cause difficulties in management, something you don't, or push it down. You don't want that. These are still in use though. This is one that's on sale right now. And so I can't tell you how often it's used in other countries. And I can't tell you how often this is a method of quick checks that it's actually used in the United States anymore, but is used in other places. And you see a little waveform on the side. But I don't know how you would document this. So, you just would, there's no capnograph to print off. It's just a little quick waveform on the side there. And this one is actually made in China. So maybe it's more common in Asian countries. I don't know. What you see most common in the pre-hospital setting now, with most newer monitors, is Sidestream End-Tidal CO2. And Iridian is pretty much the primary manufacturer of these. And you'll find these on Zoll, you'll find these on Philips, you'll find this on the Tempest, you'll find this on the new Medtronic or Stryker products. So pretty much all the major monitor platforms use the same technology and the same devices. Third-party devices. They just license it to put in their monitor. Now what this means is, we say Sidestream, is it actually pulls us, instead of measuring the main passageway of air through the ET tube, it has a little tube that constantly aspirates. It's a constant pump that pulls very rapidly, and it causes about a 3 to 5 second delay depending on the length of your tubing. Samples of gas into the monitor where it gets measured. So it's considered slightly less accurate because there's more chance of gas leakage and tube issues and connection problems. But whether that's clinically significant in our setting, I couldn't tell you. I don't think it is. They also have variations of this that are used with nasal cannulas. And as you can see right down here in the bottom. Now, key thing that most people don't realize is that the nasal cannula has to be positioned correctly. So if you just throw it on and it's half hanging in the nose and this little bit isn't hanging over the mouth, it's not going to be accurate. It has to be positioned correctly, and this has to hang out over the mouth, and hopefully you don't have a beard full of chunky peanut butter getting in the way. So how does the technology actually work? Well, this is your simulated air tract, and during inhalation, when you're pulling air in or you're ventilating or positive pressure pushing air in from the atmosphere or from your oxygen tank or from your ventilator, you shouldn't be pushing any CO2 in. It should be free of CO2. So when the infrared light is shining across, it shows nothing. This is your baseline. And then when the patient then exhales, the flow of air reverses and they're pushing CO2 back out through the tube. The End-Tidal CO2 measures the CO2 and estimates the pressure, the millimeters of mercury. And that's where you get your waveform. And this waveform shows the increase, and that plateaus until you take another breath in. Does that make sense? So things that can spoof Sidestream End-Tidal CO2. Well, if you don't have it placed correctly, if you have a lot of vapor or moisture in the tube, use of nitrous oxide can give you false highs in mainstream. I'm not sure exactly the reason why, unless I guess the sensors just confuse it for CO2. We don't use nitrous oxide commonly in the United States, but if you are a service that does, you need to be aware of this. If you have leaky End-Tidal CO2 tube, you can get false lows because as it's aspirating in CO2, it's also aspirating in atmospheric gas, which will dilute it. We talked about End-Tidal CO2. An epi can drop it by up to 5 torr or 5 millimeters of mercury approximately. This is short and transient. And we also just talked about how improper positioning of your nasal cannula means you're not getting a clean sample. you're not getting a complete sample, and therefore that can affect your waveform as well as your actual number. And that leads us to reading the waveform. So let's talk about the waveform itself. As we talked about, 30 to 35, it's measured millimeters of mercury to torr, most commonly millimeters of mercury. Now, a key point I want to point out is that, generally speaking, if everything else is properly placed, that End-Tidal CO2 greater than 55 to 60 millimeters of mercury despite intervention. So not when you first put it on, but despite intervention. When you have your tube in place, or when you've given your bronchodilator and you're giving some supplemental oxygen and their blood pressure is increased, if you still have End-Tidal CO2 greater than 55 or 60, that's a huge red flag for respiratory failure. Huge red flag. Now, there's some other things that can cause this, including malignant hyperthermia and other stuff, but none of them are good. And so if you think 55 isn't that higher than 45, we're okay. No, that's a huge red flag. All right. So I have compared previously in this lecture End-Tidal CO2 to EKG, in that we need to look at it in the same structured fashion. And I think this image where you see the graph paper and you see the End-Tidal CO2 and the EKG on graphs kind of drives that point home. Just like with EKG, where you're looking at shape, you're looking at width, you're looking at speed. This is time, this is height. Just like with EKG, you're doing the same thing with End-Tidal CO2. You're measuring the same parameters, and those parameters are frequency. In End-Tidal CO2, it's basically your respiratory rate. With EKG, it'd be your heart rate. The rhythm, how regular it is. Where your baseline is. So if we go back here, we were worried about your isoelectric line. Here, this is your baseline, which is very similar to your isoelectric line. Your baseline should be 0. If it's not 0, you're trapping CO2 somehow. We're worried about the shape. You should have a sudden increase in End-Tidal CO2, a near plateau, and a sudden decrease as you inhale in. Just like with EKGs, we're worried about the shape of your QRS complex, so you don't have like rabbit ears with a bundle branch block or anything like that. We're worried about the height. The height of your End-Tidal CO2 corresponds with the level of End-Tidal CO2. A 35 to 45 is a different height than a 55 or a 25. Does that make sense? Now we have phases. Phase 1 is inspiration. Took a breath in. And then phase 2, I take a breath out and it rises up and then it plateaus at the very end of my ventilation, or of my exhalation, I should say, at the very end of my exhalation. I've peaked my End-Tidal CO2 and I'm just breathing out the maximal level. Now, sometimes increase just a little bit, but usually it's not a lot. And we measure End-Tidal CO2 at this point right here. The exhalation, the end of the exhalation before we take a breath in, right here at back at phase 1 again. So this is not the breath in. This is just almost instantaneous drop. This is the breath in. Phase 1. Now they have points, point A, B, and C, D, and E. Pretty self-explanatory. Now remember that the capnograph only detects CO2 from exhalation. Well, I would probably rephrase that. It only detects CO2 in the respiratory tract that should only occur during exhalation. It is possible that if for some reason you have CO2 trapped, so when they breathe it in, they almost like a reservoir, they breathe in a little CO2, it will pick that up and it will alter your waveform. But you should not have that. Normally, if your BVM is working correctly, the patient's respirations are working correctly, your ventilator circuit doesn't have a lot of dead air space, your ventilator working correctly. Normally, if all that is correct, you should have 0 End-Tidal CO2 when you inspire back in, which is why your End-Tidal CO2 should always return to baseline. It should always return to baseline. Here I have these little graphics to illustrate that. If you do not have it return to baseline, you're getting additional CO2 from somewhere. And that's usually because your circuit is too long before your one-way valve. You've got too much junk in there. When you have your ascending phase, and what we're going to do in these next few slides, we're going to go through each phase. So here's your baseline. You're going to you've taken a breath in, and now you're breathing out. This is your ascending phase when you're breathing out. This is when you go from 0 very rapidly to your plateau, which is almost or at your max CO2 level when you're breathing out. Now, sometimes, and we'll talk about this later, this gets kind of, I'm going to get a different marker here. Sometimes, let me see if I can do this. This gets shortened out, and this is what we call a shark fin. And the reason it gets shortened out is because of bronchial spasm. We don't rapidly get to this point. We don't get rapidly to that point. It's a slower exhalation because of air trapping. It takes longer to get to our plateau. Our respiratory length is the same. It takes longer to exhale to reach our maximum CO2 exhalation. I hope that makes sense. So what we see here of phase 2 is the sudden uptick of CO2 as we begin our respiratory exhalation, and then it will plateau off. And this image down here that I'm pointing at, let me get my laser pointer again. This image down here makes it look like there's still a sharp increase. There won't always be. Sometimes they'll plateau out fairly nicely. So then we hit our alveolar plateau, and as you see in the blue image, it's very flat. In the black image, it still has a slight increase, but this is a very minor. This is just 2 or 3 millimeters of mercury increase, and it's perfectly fine. This is a normal Capnographic waveform. Now, at the end of this phase 3 is where, at the end of phase 3 is where we measure End-Tidal CO2. So this should be our maximal number. And if it's not, there's different things that come into play. Again, when we're at our End-Tidal CO2 at the end of our exhalation, we take that sudden breath in. This is where we have our phase 4, our sudden descent. Now, this normally should be almost a immediate, very damn near 90-degree drop-off, sheer cliff drop-off, because now we're inhaling. And when we inhale, we should have 0 CO2 in our sample of inhaled atmosphere. That said, if we do have some, if this slopes out, that means we're trapping air. There's something abnormal there. So again, our normal range is 35 to 45. So let me ask you something. Picture this End-Tidal CO2 waveform. And we'll say you normally are breathing at 20. And everything else is identical. Nothing else has changed. Suddenly we're starting to breathe at 30. Or we're breathing the patient at 30 for whatever reason. What would happen? If everything else stays the same, what would happen? Well, I'll let you pause the video, take a second, contemplate it, and contemplate for frequency, duration, height, and shape. So pause now. Okay, welcome back. So if I change nothing else but the frequency, what I would see is the waveform would still be the same. But because the production of CO2 didn't change and so on and so forth, because we're emptying out CO2 faster, eventually this height would drop down. It might be at 25 or 30 instead of 35 to 40. So the shape would be the same. There would be more of these because of more frequency. But the height would be less because we have less CO2 to measure with each breath. That's assuming that our end-tidal CO2 production is unchanged. So what we see here is a normal capnograph illustrating this. And then we see hyperventilation. So the shape is the same. They're just shorter because same amount of CO2, but being ventilated out at a substantially faster rate. So our height is less, but the waveform is the same. The exact opposite is true. We have a normal capnograph, but we slow down breathing. So we still have the same amount of CO2 to get rid of, but we're doing it over fewer breaths, so our height increases. If we breathe slower, the duration of our breath increases. Okay, so if we exhale slower, as an example. Now the question is this a good thing? Is this a bad thing? Does it even matter? And the answer is, if you think back to how end-tidal CO2 affects PaO2, PCO2, if you think back to how end-tidal CO2 affects PCO2, and then take that a step further in how PCO2 affects pH balance, how it affects vasoconstriction in the brain, how it affects so many other metabolic processes, deliberately changing end-tidal CO2 can have deliberate and sometimes adverse effects on the entire body. Deliberately changing end-tidal CO2 has direct effects on the entire body, on its pH, on its PCO2, on vasoconstriction and perfusion of the brain. So with that in mind, don't chase the number. We used to teach paramedics, that we want an ideal end-tidal CO2 of 35 to 45. We have somebody that's been down for 3 hours in not true respiratory rest, but definitely hypoventilation, and their end-tidal CO2 is really high. We used to have paramedics like, oh, I need to bag that down. And they would bag at 30 breaths a minute, or 40, trying to get your end-tidal CO2 down to what they think is a normal range. Well, in doing that, you can cause air trapping, you can cause barrel trauma, and that attempt to drop can have end-tidal CO2 effects. We might be worried about, another example would be head injuries. Even dropping the end-tidal CO2, and there's been studies on this, between 35 and 45 is normal. Dropping it below 30 with hyperventilation status, somebody's bagging the heck out of them, and they drop it down to 29 or 25, significantly increases brain injury, and also significantly decreases neurological outcomes. So what the lesson here is, do not use your end-tidal CO2 to try to make changes to their physiological status. Use end-tidal CO2 to monitor their physiological status. Use it to guide your treatments, but don't try to, I just need to bag them down to a certain number, because you can kill your patient. Let's talk about use of capnography. When is it indicated? Well, if we look at apneic patients and intubation, it is considered the gold standard in tube conformation. Now, I want to stress this, gold standard tube conformation, but not only tube conformation, and immediate tube conformation. A properly placed tube will always produce a clearly identifiable waveform. Now, the details of the waveform, such as the number, the height, the frequency, that will vary on other things that you're doing with your patient. But it has a sensitivity and specificity for tube placement of 100%. You will never have a gut tube with a good end-tidal CO2 waveform. Conversely, that's pretty much it. It's 100% sensitive. So you have to do this. I mean, it's if you have a gut tube, you go to court, you don't have end-tidal CO2, you're screwed. Bottom line. If you go before your medical director, you don't have a good end-tidal CO2 waveform to prove that tube is in place, you're screwed. If that tube gets dislodged on transfer over to the ER bed and they put on End-Tidal CO2 to confirm placement, they will have a waveform they can point to. If you don't have one immediately before, it's on you. The assumption is it was a gut tube the whole time. Now, here's another thing, is you have to do it immediately. So if you get your intubation, you move on to other things, then you put on your End-Tidal CO2 10 minutes later, has it done you any good? No. Because you had 10 minutes of potential time when the tube could possibly have been dislodged and you would have had no idea. You need to get it on quickly and promptly. The American Heart Association even goes so far. You know how the AHA takes forever to weigh in on anything. Even the AHA says when CO2 is detected in cardiac arrest, it's still a reliable indicator of tube position in trachea. So even in hypoperfused states, if you're doing compressions and moving blood around, you can get a good End-Tidal CO2 waveform. Now the number for your End-Tidal CO2 may not be where you want it to be. It may be 25, maybe 20, maybe 15. But if there's any CO2 production at all and you're moving any blood at all, you should still get a normal shaped waveform. And that's why the waveform is so important. Another study in the Annals of Emergency Medicine, I really want you to take this to heart. No, zero, nil, zilch, unrecognized, misplaced intubations were found in patients who paramedics used continuous, not single use like with colorimetric, but continuous End-Tidal CO2 monitoring. Failure to use End-Tidal CO2 monitoring was associated with a 23% misplaced intubation rate. 23%. Now at this time you think, man, those paramedics, they just must really suck. Well, a 23% misplaced intubation rate roughly corresponds to about a 77% first pass success, which is about normal in many EMS systems. So when you think about that, what failure to use End-Tidal CO2 basically means that the paramedics think they got it, and they listened to lung sounds, they did everything else they're supposed to, but they didn't recognize it as a gut tube. And I'm telling you that this happened all the time before End-Tidal CO2 became mainstream. All the time. Competent paramedics, diligent paramedics, experienced paramedics. Even if your first pass success rate was higher than this, that it still is never 100%. And a combination of confirmation bias as well as the chaos of the scene and sometimes human pathology all resulted in paramedics who, well-intentioned, thought they had it in the trachea, and did everything else they're supposed to, still missed gut tubes. End-Tidal CO2 is the only thing that is almost like a third-party assessment, a neutral assessment that will tell you assuredly whether you're in the trachea or not. Now, here's something else I want you to bring in mind, is that if possible, if you can get End-Tidal CO2 before you intubate, do so. If you can get End-Tidal CO2 before you intubate, do so. Thinking why? So if you have, say you put your End-Tidal CO2 on your BVM mask and you got good two-handed seals so you don't have air leakage, you got good air position, you're moving air in and out, and your End-Tidal CO2 is 30 or 40, whatever it is, 35, we'll just say 35 as a magic number. And suddenly you intubate and your End-Tidal CO2 is 25, something is amiss. You should see at least the same number or an increase. If you don't have a good comparable number after intubation compared to before, that tube is hanging right at the carina, or right at the tracheal opening, is about to be dislodged, or there's something else. Sometimes, if you're in a gut tube, the first 3 or 4 breaths, like what you see here in example B, if you just look at the first 2 breaths, you might think, oh yeah, it's in place, but this is less than what it should be. Sometimes you may have CO2 in the tube, and CO2 that gets shoved into the gut, and you breathe it out with a couple of breaths. So that first 3 or 4 breaths may be misleading. They will decrease, but they look like a normal waveform. You have to watch for probably, I don't have a solid number for this, I don't have data on this, but probably at least 5 or 6 breaths to make sure that your end-tidal CO2 is comparable. So please, 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 if you can, get end-tidal CO2 before intubation as well as after. And if you can't, don't just look at 1 or 2 ventilations and say it's good. Have somebody look at it and watch it, or you, for at least, we'll just say 6 ventilations. And not 6 rapid ventilations, 6 normal ventilations. Okay? So about 30 seconds worth. It will save your ass someday. Okay, so let's take a moment to look at a case where where end-tidal CO2 could have had profound implications. Now this is Drew. Now Drew was 14 years old and he was skateboarding. He had his head hit his head on some pavement. By all accounts, a smart, well-liked, fun, exuberant 14-year-old. He was transferred from point A to point B. And during transfer, he became somewhat combative. So what the paramedics attending him did is they made the decision at about 11:15 to sedate him and paralyze him and put him down, or to keep him down. I mean, keeping him down to control his airway, because the presumption was it was closed head injury, and he was decompensated, become combative. And actually, this is probably, depending on the other factors, is probably a reasonable conclusion. So they sedated him. They paralyzed him with vecuronium. Now, as paramedics, you should know that vecuronium has a long, say 20 to 40 minute clinical duration compared to succinylcholine, which has a much shorter clinical duration. But they put him down, per se, and then they were bagging him. And what we know is that they document they bagged him for about 3 to 5 minutes with 0 difficulty using a BVM. Now, there is some consideration that perhaps he still had some mental status at this time, because they, due to some questions about sedation that was given. But during this time, during bagging, that we know from the monitor record that his SATs were in the upper 90s, which is ideal. That's where it should be. Now, they did this at 11:15. They bagged him. They prepared everything. And at 11:20, because they'd already given the paralytic, they decided to intubate him. Now, this is actually, I have no problem with them taking 5 minutes to get to this point, as long as he has no gastric distension, because you are pre-oxygenating him. They are doing what they should. At 11:20, they intubated him. And immediately at 11:21, his SATs went from in the high 90s to 86%. That alone should have been a red flag. By 11:23, 3 minutes later, his SATs dropped to 40%. So at this point, that should have been a huge red flag. Okay? So for whatever reason, they didn't necessarily register this. And by 11:25, his SATs were unreadable. His pulse rate had dropped with severely bradycardic in 30s, and there was no palpable pulse. Now, at this point, we, as paramedics, you should know that bradycardia and hypoxia go hand in hand, especially in the setting of intubation. This is a classic example of the patient decompensating and coding. So the question is why? Well, what we know is that when they quickly diverted to close facility, when they got there, they put end-tidal CO2 on him and found that his end-tidal CO2 was 0. He had a gut tube. And you're thinking about, okay, well, what did the end-tidal CO2 say before then? They didn't have end-tidal CO2 on. If they put end-tidal CO2 on immediately, because they intubated at 11:21, if they put it on at 11:22, they would have noticed immediately that his tube was not in place. They would have pulled it. They would have either re-intubated, used a rescue airway, or gone back to bagging because they were successful at bagging. They would have problem-solved the problem. They would have troubleshooted the problem. And Drew would be alive today. Unfortunately, by the time they got to the transferring facility, cardiac arrest in process and everything else, 30 minutes without End-Tidal CO2, 30 minutes with a gut tube that nobody recognized. And you can kind of imagine how chaotic this was and how stressful it was for the paramedics. Thinking there might have been some confirmation bias that, oh, he's decompensating, now he's continuing to decompensate. By the time they drew lab work, his CO2 level was 88. Now remember that your normal PA CO2 level is supposed to be 35 to 45. It was almost double that at 88 millimeters of mercury. His pH, remember your pH is supposed to be 7.35 to 7.45. His pH was 6.8, generally considered close to non-survivable. So as we know, PaCO2 and pH have a relationship. Therefore, we can tell clearly he wasn't being ventilated because it was building up in his bloodstream. So we know that he had mental status before this event, before he became combative. We know that he had good SATs before intubation. The question is what happened between intubation and the ER, and we can assume from the data that we do have, his pulse ox, his heart rate, stuff like that, that it was a gut tube. We have no clear knowledge because they didn't have End-Tidal CO2 in place, but we know it was displaced when they got to the ER. Presumably, End-Tidal CO2 would have saved Drew's life. It would have saved these paramedics' career. So what does a properly placed End-Tidal CO2 look like on a properly placed endotracheal tube? Like a normal End-Tidal CO2. That's what it looks like. You have the frequency of whatever you're breathing at. You have a good upstroke, when you breathe in, you have a zero baseline. When they start to exhale, you have a good upstroke, rapidly getting close to their maximal maximal CO2. You have maybe a slight perceptible uptick at the end where you measure End-Tidal CO2. Then as you ventilate in again, you have a sudden downstroke to zero for your baseline. That's the way it should look. It looks like a normal End-Tidal CO2. When you have sudden dislodgement, you will have breath, and then often nothing. And this would be a case where you hit a bump, or maybe it's just bad luck. Maybe the tube was just barely through the trachea. Whatever it was, it doesn't matter why. When you see this, the tube is not there. And this is like 7-Up. You never had the tube to begin with. You don't have it now. These little blips, these are nothing important. These are so close to baseline, they're inconsequential. You cannot assume that this is a viable End-Tidal CO2 reading. This might be a little leakage from the respiratory tract into the gut, whatever the case may be. You should have a clearly identifiable plateau that associates with your respiratory rate and your whatever you're doing for the patient respiratory rise. So I get asked, well, can you get End-Tidal CO2 with a gut tube? Kind of. So if the theory is the patient has lots of carbonated beverages which have CO2, or if mouth-to-mouth ventilation has been attempted before they are ventilated, you may have some CO2 in the gut, and you may detect that a false positive with a gut tube, but it should rapidly decrease to zero within 3 to 6 breaths, and it will not be normal looking. This is why even with End-Tidal CO2, we always use multiple confirmation methods, but this is also why you look beyond the first 3 to 4 breaths. Okay? So that's an important consideration. So in the end, there can be only one. In other words, one absolute rule, and that is you have to have End-Tidal CO2 with your waveform. No waveform, no tube. No waveform, no tube. Doesn't matter what else you think you got. And the reason why I say that is that 23% missed tube, unrecognized gut tube rate with no end-tidal CO2. Remember that 23%? I doubt those medics said, it's a gut tube, I don't care. They all thought they had it in place. They all probably, presumably, did other methods of confirmation and still missed it. So I've talked a lot about your waveform should return to 0 at a baseline. So what happens when it doesn't? And here you have an example of a baseline that's slowly rising. What's happening there? Well, somehow you are trapping CO2, or not trapping, you are rebreathing CO2. Now this may be a vent circuit problem, maybe a vent problem. It is probably related to your BVM or your one-way valve on your circuit, and that's not working correctly, so it's not allowing the patient to completely exhale. So during the next breath, CO2 is being pushed back in. This is a concern because if you're trapping or you're rebreathing CO2, there's always a concern you're also paper bagging, or you're about to cause some barotrauma with even normal breaths. So when you see this as a raise in baseline, look and make sure you're not breath stacking. Okay. Here's another you will sometimes see, and this isn't the greatest example. But what you see here is you see an increase in tidal CO2, but not a clearly defined waveform. So you're getting CO2 from somewhere. The question is where? Well, this is most likely a leaky cuff, or there's air CO2 escaping around the cuff, so you don't have the normal plateau or vent circuit failure. Or what I've seen is where the BVM is partially detached with the end-tidal CO2, so it's getting air, it's sampling atmospheric air as well. This requires immediate attention, but doesn't mean the tube's not in place, because you still have consistently good numbers. It's just the waveform, and again, you have to look, does this correspond with my ventilations, etc. This is concerning, but it's probably a leaky cuff. Here's what it could easily be. You take your syringe, you inflate the cuff, and then you leave the syringe attached to your tube, and it just backflows and your cuff deflates. That could easily cause this, but you need to figure it out, and figure out immediately, because you can't leave it like this. If it's like this and you can't figure out why, you need to consider if your tube's misplaced somehow. And by that, could be right at the just the tip of it, hanging right in the glottic opening, but the cuff is out of the glottic opening and it's just waiting to be dislodged. That's the worst case scenario. Now, sometimes you may have an obstructed ET tube, where you have an irregular waveform shape. You still have increases in your end-tidal CO2, but what you don't have is a good, well-defined plateau. So this could be a leaky cuff. This could also be a partial obstruction, like a big mucus plug at the end. So with any of these, I think it's always important that the very first thing you check is your dopes. And there's a reason why dislodgement is the very first thing, because dislodgement is the worst case scenario and you want to catch that immediately. But you need to look at obstruction, pneumothorax equipment failure, and stacked breaths as well. So this is something that sometimes you have a leak in the sampling line. And I'll be honest, I've had leaks in the sampling line. I've never actually had it look this way. I've just had floppy waveforms. But I found several documentation of this, where you have a sudden increase in end-tidal CO2. And this is basically normally what would happen. Let me get to my pen. Is normally what you'd expect with this is it would drop down and return to baseline. What they're saying here is that there's some CO2 trapped with dead airspace, and suddenly you have an increase as it's being pushed back. So I've never personally seen this, but this is a specific waveform that's mentioned in the literature, and it might mean that your end-tidal CO2 is not screwed in correctly, something like that. Again, Anything abnormal, as a good practice, do your dopes check really quick and then troubleshoot the obscure zebra stuff. Now, this is something you do have to be familiar with. This is called the Chiari cleft. And basically what it is, it's spontaneous breathing. Okay, so I got my pen here. Normally what would happen is you would expect this to come down to 0 and then come back up, come down to 0, that type thing. And what this is not a continuation of your respiratory effort. This is the patient happening to have a respiratory effort. Let me just shade that in a little bit. A little bit of respiratory effort. This part right here is the patient's own respiratory effort that just happens to be in synchrony with your ventilatory rate by some random happenstance. So this little notch, what you're seeing here, is all the patient attempting to breathe on their own. Now, is this a good thing? Is this a bad thing? Is this expected? Is it not expected? Well, that's a good question. And what it depends on is the patient's clinical context, what's going on with the patient. But if you expect them to be fully paralyzed and sedated, then this tells you they're not paralyzed. This tells you your sedation may not be strong enough, and I would consider redosing. Here's another example. Now, this one isn't necessarily in synchrony with your breath. But what you have here are some spontaneous respiration attempts. They're not full, they're not great, but they're a clue that your sedation and paralysis is wearing off. Now, good clinical practice. So if you're tuning out, tune in here. Every time you consider reparalyzing, administering more vecuronium, rocuronium, whatever your paralytic is, you absolutely need to give more sedation. Okay? Paralyzing a patient without sedation is inhumane to the point of being a crime against humanity. Having somebody who's paralyzed and yet has some lucidity at all is known to be terrifying. PTSD inducing even. There's a whole subclass of PTSD related to this. So if you re-administer a paralytic, you need to re-administer some sedation, assuming their blood pressure will tolerate it. And if their blood pressure won't tolerate it, maybe give a reduced dose or something, but you don't want paralyzed patients to be awake at all. Anyway, so some other things I would look at for this, just a little clinical pearl. And this, it doesn't always have to be the same shape. It can be little notches. I've seen little bumps, but it can also look at their heart rate. Sometimes you'll see the heart rate increasing before you see this. That's a sign of pain response. Another sign they need, if their blood pressure tolerates it, they need more sedation. Cool? There's examples of the Chiari cleft. Here's a real actual incident. So I'm going to see if I can change my pen again here. Actually, I want to do my laser pointer. Here's a bump. Now I want to point out something. So what you see here, there aren't a lot of pre-hospital monitors that do that. The new Zoll, they have an option for this, airflow monitoring, which I think is actually pretty damn cool. But you aren't seeing this a lot in the pre-hospital setting, but you will see this in the ORs. You will see this in critical care. So this is your End-Tidal CO2. So here's your inhalation. Then you exhale. And then suddenly inhalation, exhale. Now this is airflow. And I have this listed as O2, but it could just be a mixture of any gas. Could be room air on a ventilator, right? So you see the exact opposite. When they're exhaling at 0 and when they breathe in, you see it peak up. So this is a really neat thing about both monitoring airflow in and CO2 out, is you see this notch. Now the notch just happens to occur as the patient tries to take a breath in and then exhales to some degree, and this whole thing here may not be all exhalation. It just may be continuation of the ventilation controlled exhalation. And return down, and then you see this notch down here corresponding. This is inflow. This is the patient breathing in, and when they breathe in, CO2 briefly drops. So you can match these up and say absolutely this is lack of sedation. The patient needs more sedation, so on and so forth. This is a great example. Now, reality, unfortunately, is in most pre-hospital setting services today, maybe not in 5 years or 10 years, we do not have access to this information at all. We just have access to this. So you have access to your End-Tidal CO2, you have access to your pleth, an EKG somewhere. I guess this looks like possibly an EKG, those type of things. Okay, actually that may be hemodynamic monitoring up there, but you get the idea. So when airflow monitoring becomes a big deal, which I think it is in 10 years, you will have a fourth dimensional assessment as well. And I think that's going to be very useful. Here's another example. So let's see what we have here. This is your End-Tidal CO2. And then here's your airflow monitoring. So you see the bump combined with the cleft, and this is patients breathing fairly rapidly, right? Now understand that there might be a case where this is expected, like with pressure support, and the patient, you want them to have some respiratory effort. So some clinical context is important. And you're like, well, how do I know if they need sedation? Well, heart rate's a great example of that. And here's another example of normal. So you have a breath in, corresponds with your base return to baseline. You have exhalation, which corresponds with your End-Tidal CO2. That's great. This is, I'm not sure what they're trying to show here. I think that's I think that's hemodynamic monitoring, so not 100% sure there. So what about End-Tidal CO2 with low perfusion states, such as shock and CPR? Well, they've studied extensively. And as long as you have some pulmonary blood flow, even if it's crappy, and you have some metabolic activity, you will still get a normal shaped waveform. It just, the numbers might not be as high because you're not producing as much CO2. And here's the really neat thing. If you're cooking along, you're doing CPR, and you have your End-Tidal CO2 and tube in place, and your End-Tidal CO2 is at 20, and suddenly it drops up to 40 or 50, that's a good thing. It means you're about to get pulses back. The opposite is also true. Say you just resuscitated a patient, and you're about to consider going down the hallway, you're patching up, and suddenly your End-Tidal CO2 comes from 40 to 20. Still a good waveform. I want to stress this. Still a good waveform. The waveform is the proper shape, has a plateau, everything, but the number drops. That's a sign that within the next 2 minutes, the patient's about to code. So what does that inform you? Does that mean you rush out to the ambulance? No. It means you stop what you're doing and you get ready to work the code again right there, so there's no break in perfusion. It means you stop and reset to work a code instead of a post-ROS. So this is also useful in telling difference. Well, are they truly PEA or just a low flow state? Because that can change your treatment plan, stuff like that. So here's an example. This is a great example. You have good End-Tidal CO2, you have good waveform, but the actual level is just dropping. This is a sign that the next 2 minutes the patient's going to code, maybe less. This is the exact opposite. You're doing normal CPR, it's at 20 and suddenly increases, or it's at 10. Well, looks like about 15 to 20, and then suddenly increases to 30 right there. That's a sign you may have pulses on your next pulse check. Now, there's some increased question that maybe End-Tidal CO2 can help you judge compression effectiveness. So if you got good End-Tidal CO2 during CPR and it drops, you need to look at recoil, you need to look at rate, you need to look at compression depth because something's failing there. Now, capnography is a predictor of survival in cardiac arrest. Now, this is both useful and can be, again, if you just take it at face value, it can also be misleading. This was a good study, 400 patient study in 1990. Now, remember how I told you that back in the older days, they used, instead of millimeters of mercury, they used torr, which is which is what they did. So, this was a case, and torr is roughly equivalent to centimeters of water. So this was during compressions. Now, I have to understand this was not high performance era. This was old school, 5-to-1 or whatever they did back then. The average initial end-tidal CO2 in the group that got ROSC was 18 torr, which is very similar, 18 millimeters of mercury, compared to 6.7 in the non-ROSC group. So this is really high, really informative. The final end-tidal CO2 in the ROSC group was average 26 versus 7.5. So basically, when they did all the statistical assessment and everything, no patient with an initial end-tidal CO2 of less than 9 survived to admission. Now, what does that mean? Well, another study followed this up, found similar results. This was done in 1997. So we've had at least two, actually multiple studies looked at this, is that if you have an end-tidal CO2 of less than 10 millimeters of mercury after your interventions, after 20 minutes, it's a predictor of death and mortality, even if they have electrical activity such as PEA or VFib. And it says cardiopulmonary resuscitation may be terminated in those patients. So what does that mean? Does that mean if you take the study at face value, you think, okay, well, I'll work them 20 minutes. If their end-tidal CO2 is still less than 10, I can call it. Yes and no. And this is what I say, is that it is probably a very important parameter, but I still look at other factors. I'm really reluctant to base any high-stakes decision on one single parameter, but it's an important assessment. Low end-tidal CO2 alone is not an indication to terminate resuscitation, but it's an important consideration. But I will say that if after 20 minutes or 30 minutes or 40 minutes or 50 minutes or 60 minutes or even longer, that if you have a good end-tidal CO2, continue resuscitation. So I want to say that again, that even after 20, 30, 40, 50, 60 minutes, if you have a good end-tidal CO2 greater, I'll say 25, but definitely in the 30 to 35, 45 range, you still have a good end-tidal CO2, you still have metabolic activity, really strongly consider prolonged resuscitation, even if they're asystolic, even if they're VFib, whatever it is, no matter how tired you are. And here's why. This is a prime example. This is Howard Schnitzer. Now, he was 59 years old, just got done working out, was walking down. I literally, when I described this place as Mayberry, that is really what it was. It was in a very rural part of America, very small town, no ALS, volunteer BLS, so far removed from what we would normally consider an urban area, it took an hour for the helicopter to get there. Think about that. So, he, in public view, goes into cardiac arrest, falls down the street. Two guys who are mechanics or whatever walk over from the garage across the street. People in the cafe nearby come out and they start doing CPR. Fire department arrives. They put him on the AED. They've shocked him. He's just not coming out of it, but they're working the hell out of him. They literally have a conga line of people willing to stand in line, and every 2 minutes a new person gets on his chest, so everybody's refreshed. These volunteer firemen are on top of it. Somebody somewhere told them the value of high-performance CPR, and they are kicking ass. The ALS crew shows up at approximately an hour after of downtime. They walk up, and they see this conga line, so they're impressed. But they're like, this guy's been down an hour. Is he really got a chance of survival? They intubate him, they start a line, they put end-tidal CO2 on him. So this is the first ALS they've had, is an hour with just BLS. First ALS they have. They would have normally called it, but after an hour. But his end-tidal CO2 is in the 35 to 45 range, so they keep working it. He's in VFib. They shock him a total of 11 times. They keep working it. They're now at an hour and 30 minutes. 11 shocks. He's still got good end-tidal CO2. The only reason they didn't call it was because of his end-tidal CO2, and then he resuscitates. They get Ross back. They convert him. And guess what? After 96 minutes of CPR, 4 days later or 3 days later, whatever it was, he walks out of the hospital with no neurological deficits because of high-quality CPR and because which was the reason why he survived, and because of end-tidal CO2, which is the reason why they gave him a chance to survive. So I really want that to really be driven in. Let's talk about the use of capnography in spontaneously ventilating patients. We hear about the shark fin. I talked about this. The shark fin is nothing more than asymmetric release of end-tidal CO2 into the exhalation phase because of bronchial spasm. So if I look at my pen, or I'm going to go highlighter here. If I look at my highlighter, normally you see where it comes up, normal plateau. Because the bronchial spasm, they can't release it as quickly. So we see on the front end of the exhalation a more gradual increase in end-tidal CO2. They're still breathing the same cycle. It just took longer to get to peak. And then when they breathe in, of course, it returns to baseline. So in mild asthma, and this is not 100%, what we see with mild bronchial spasm, CO2 will drop because it's not releasing as well, and the patient's breathing faster to compensate. However, even despite this, the CO2 will eventually rise, and when it becomes very severe, like say above 50 or 55 or 60, as I talked about earlier, you will see the shark fin with really high end-tidal CO2 levels. That patient's on the verge of tiring out and will very likely need intubation if they don't respond to other intervention. So here's an example. Notice your respiratory rate's at 38. They're breathing really fast. Because they're breathing off to compensate, their end-tidal CO2 is lower than normal. Now they're tiring out. They're starting to slow. Their end-tidal CO2 is rising. And now they're really tired. End-tidal CO2 is pretty high. So we call this the shark fin. And the nice thing, you look here because it kind of looks like that. The nice thing is that it's a great, when your interventions work, such as bronchodilators, it shows that. And here's actual end-tidal rhythm strips. So here, end-tidal CO2 was crap. I mean, just absolutely crap. Matter of fact, I mean, this is a waveform, but it's not a great waveform. Notice you got shark fin here, shark fin here. So it almost looks like this would be, depending on what their level is, and I can't tell if it says it on here. So this is 50, this is 25, that's 30, this is probably 15. This is low, this is scary. And then here, after treatment, 3 minutes later, look at this. We still have shark fin, but look at how much more end-tidal CO2 is being released. I like that. And then here's your second one. So this is probably around, that's 25, that's above that. Here we are. Now we're still only about 30, but now we have a much better plateau, much better waveform. So I like that. So we don't know how effective this is in pediatrics. And the reason why I say pediatrics is because lower tidal volumes mean it's sometimes harder to, it's just harder to take. But also, as end-tidal CO2 technology improves, this becomes more accurate. So just be cautious about looking for shark fin in pediatrics, especially neonates or infants. with this. Okay, let's talk about end-tidal CO2 and head trauma. So if you aren't aware now, there is a thing called hyperventilation for head trauma to decrease or vasoconstrict blood vessels in the brain and allow basically more space for swelling to occur and therefore lower intracranial pressure. This is a very short, last-ditch effort, and it is not. It's a bridge to decompression of the skull or any number of different things. The problem is it's a gray area because when you vasoconstrict too much, you decrease cerebral perfusion and you kill brain as well. So they used to say, well, just hyperventilate. And they said, well, what is hyperventilation? Because we found out people were bagging 30, 40 times a minute. Well, then they used to say hyperventilation is really just bagging at 20. But we suck at gauging our respiratory rate. So they found when they put end-tidal CO2 on and said, here's the respiratory rate I want you to bag at, not the number, but the rate, that they had higher compliance. So they had lower instance of hyperventilation compared to those without end-tidal CO2 monitoring. Now, both patients, regardless of whatever, if they had severe hyperventilation, they did very poorly. Granted, all of them are doing poorly, but a 26% increase in mortality is nothing to ignore. So what this tells us is end-tidal CO2 to prevent hyperventilation is crucial. Crucial. So if I put a fireman bagging the patient, I'm just using a fireman because that's what we use in our area, or an EMT of any type, any flavor, I'm going to point to the number and say, I don't want your respiratory rate to get above whatever number that is. I don't care how high their end-tidal CO2 goes. Okay. Another study also showed similar results, but this time looked at end-tidal CO2 as a predictor. So if we bagged them so much that their end-tidal CO2 dropped below 30, if we bagged them so much that their end-tidal CO2 dropped below 30, their mortality increased. And it doesn't take much. The difference between 26 and 30, very, very poor. Very, very small. So it's really important to keep a good respiratory rate and to not let people hyperventilate head trauma patients. So that brings us to the end. So I want you to remember that big pitfalls. Number one, do not intubate patients without applying an end-tidal CO2 immediately afterward. It's the gold standard. And if you want to be pro-level, super-duper paramedic, get an end-tidal CO2 reading on your BVM beforehand. The greatest failure is focusing on end-tidal CO2 and ignoring the clinical picture, or vice versa. So that goes back to treat the patient, not the monitor. I would not say treat the patient, not the monitor. I'd say treat both the patient and the monitor holistically. Wrap it all together. And finally, don't chase the number. Don't chase the end-tidal CO2. Trying to bag them down or bag them up will cause physiological changes throughout the body that are not good. So with that in mind, that brings us to the end. I hope this was useful. And what I would like you to do right now is to take a brief moment. We're going to pause the video, get up, do whatever. Then we're going to come back. We're going to have a quiz. Okay. So pause. Welcome back. So what we're going to do is I'm going to show you a graphic of an end-tidal CO2 waveform. I'm going to ask you what's going on. And then you'll pause. You'll come up with a hypothesis on your own, and then you will see if you're right. So what's going on here? I'm not real happy with this waveform, but we have an increase down, a floppy waveform going down more and going down more. And here's your trend, came up high and went down quick. So what's going on there? This is a patient that you just intubated. So pause and contemplate. This is, in the context of this is basically missed intubation. This is a patient who you intubated. They had some CO2 in the rest and somewhere, and it went down quickly, maybe in their GI tract. And then, as I said, you can't look at just one ventilation. You got to look for at least 5 or 6. And you don't have a great waveform. You have crappy numbers, and they drop quickly. This is a gut tube. Okay, here we go again. What's going on here? This is a tube you've just placed. So, and you're watching the waveform, and this is what you see. So go ahead and pause and contemplate. What you have here is this is a good waveform. You have an uptick, you have plateau, you have a sudden downtick as you inhale. Here you have the sudden uptick like you should, but you have a crappy down. What's going on there? And you have it again. Well, this is a leaky cuff or some other inadequate seal. It's too small. Probably not too small because you have a good one here. This might be the case where you left a syringe attached to the cuff. So here you go. This is a patient you've intubated, and you have them on the fireman's bagging them or EMT's bagging them. Okay, and you notice that your end-tidal CO2 is rising. This is not a cardiac arrest. You look here at your trend. Notice your trends. This is why trends are handy when you have a graphic representation like this. You notice that your trend is rising. So what's going on here? What's going on here? So I'm going to ask you to pause and contemplate, and then tell me what you think it is. So what you have here is you have an increase in end-tidal CO2. It could be from an increase in metabolic rate, a decrease in tidal volume. So if you're not ventilating as much, you still have the same amount to wash out, or a decrease in respiratory rate. But we know this isn't a tube failure because your plateau, your waveform is all good. The question is either ventilation, oxygenation, ventilation, perfusion. One of those factors is at play. This is the other one. We don't deal with this as much, but rapid rises in body temperature, big issue if you're giving sucks or certain other medications. So I want you to take a look here. And here you have a patient's intubated, but you notice an increase in your baseline. An increase in your baseline. And you notice, you see that reflected in your trends. Now, do you remember what this is? Notice that you breathe in, but you never return to your baseline. You never return to zero during inhalation. So pause and contemplate. Well, what you have here is you have air trapping of CO2 in your respiratory circuit. So most likely, this is your one-way valve, either on your vent or BVM, is now allowing complete exhalation of CO2, and you're rebreathing it. This also can be a sign of air trapping in the at the lower airways, and this always requires prompt, immediate attention to make sure you're not stacking breaths and about to blow a lung. But you need to figure out what's going on. So here we go. We're going to take another one. This is our last one. So this is a patient intubated. You're on a transport. Maybe you're 30 minutes into it. Maybe you're 10 minutes into it. Doesn't really matter. And you start noticing these little blips, these little bumps. Your level hasn't changed. Your baseline hasn't changed. But you get these little divots here. What are they? Pause and contemplate. So this is the Curie cleft that we spent time talking about. This is a sign, and you can also look at your heart rate. This is a sign that the patient's starting to breathe over your machine, which may or may not be something that you want. It's maybe a sign your sedation paralysis is wearing off. So that's something you need to consider. Notice your trend is the same, but your waveform is the clue. And with that, we're done. And I hope this was useful, and see you out there. Thank you.